Okay, so good afternoon. So the idea behind this lecture was to at least try to drive you through a multidisciplinary approach of some pancreatic lesions. I will not review all the tumors affecting the pancreas. And to emphasize the role of the different people involved in multidisciplinary meetings to achieve the correct diagnosis and hopefully the good treatment. So let's see the first case. This is a young woman who presented for 10 days epigastric pain associated with nausea, no vomiting, discrete weight loss, and one bout of fever. The past medical history was more remarkable on the family side. Her mother had an Hodgkin lymphoma, the father a genital squamous cell carcinoma, and the grandfather a head and neck cancer. The laboratory data was unremarkable with the exception of CRP, and a CT, a contrast-enhanced CT, was performed. So everyone can see that you have a very large mass occupying the epigastric area and the area of partially the body and tail of the pancreas. The mass is heterogeneous. You may have some enhancement in the periphery, but basically this large lesion is an hypovascular lesion. On the MR, you may see that you have a very large cystic component, and this clearly emphasizes that even without contrast administration, MR has a much, much better contrast resolution than contrast-enhanced CT, at least for this specific case. You have other areas of hypointensity inside the tumoral lumen, and on the axial view, T1 weighted imaging, part of this internal content is spontaneously hyperintense. The MRCP, which basically in this case doesn't have any added value, just showed you, since the mass is quite large, but mainly it's a cystic lesion. We are here dealing with a very long echo time, and the main pancreatic duct that you may see here downstream to this large lesion is normal. So my first question is about the management of this patient. What should be the next step? Should we go immediately for surgery? Should we perform another modality such as PET-CT or EUS associated with a fine needle aspiration biopsy? Should we go for ERCP or just follow up this lesion? So please vote now. Okay. So very good. I must say that I would have appreciated that in the multidisciplinary meeting, but since the radiologists are not always followed in their advice, so we took another step for this specific situation, and indeed this lady had first an EUS, which basically displayed what we already knew, that we had a very large multicystic mass with a thick content that must probably explain the hyperintensity on T1 weighted imaging on the MR side. Then the main pancreatic duct and the common bile duct were normal, and at FNA the cytology did not display any malignant behavior. The CEA on the cystic fluid was on the normal range. The triglyceride level was normal, and the bacteriology came out as negative. The interesting point here is that even with FNA, histopathologists are able to perform immunostaining, and probably this is the way why we went for FNA in this particular case, since in some institutions, people around the table, they don't like surgery to be a diagnostic test. So in this particular case, all these markers, CD10, vimentin, and particular beta-catenin were positive in the immunostaining. On the opposite side, chromogranin and synaptophysin were negative. So this is the rat-pat summary. You have a very large mass with a major cystic component in a young lady located in the tail of the pancreas, or at least in the region of the tail of the pancreas, without malignant cell behavior and beta-catenin positive. So I will ask you now for the diagnosis. Could this be a cystic lymphangioma, SPN, a pseudocyst, a mucinous cystic neoplasm, or a pancreatic endocrine tumor? So please vote now. Okay, so that's a nice, nice answer, since I can discuss that. So the mucinous cystic neoplasm in general, it's located in the tail of the pancreas in the majority of patients. It's mainly affecting women in the vast majority of patients, but age at diagnosis is a little bit later. A pancreatic endocrine tumor, even from the imaging side, we don't have enough enhancement even in the periphery of the lesion to address that. And in addition, from the histopathology information, we know that synaptophysin and chromogranin immunostaining are both negative. The cystic lymphangioma was one of the hypotheses, and that's why the triglyceride level was addressed during the FNA under endoscopic ultrasound guidance. And as I mentioned, it was normal. So we came out with two diagnoses, B and C. The pseudocyst is less likely, since this patient had no history of pancreatitis in the recent years or months previously to coming to the hospital. So let's see, a splenopancreatectomy was performed. Here you see the macroscopic specimen, which is exactly fitting the MR and appearance. You see the cystic component with this very, very large hole, and the solid component with a mixed pattern with small cystic areas diffusely distributed among the solid component. There was a very low proliferation index. The Ki-67 displayed a very low proliferation index in this particular tumor. And finally, the diagnosis was a benign solid pseudopapillary neoplasm, which is a very common lesion in this age group, and particularly in female patients. So I have here a summary of the findings related to this specific tumor. There is a malignant potential associated with these tumors. 10 to 20% of these tumors may present with malignant potential, and specific features on the immunohistopathological side is the fact that you have for immunostaining a beta-catenin positive. And CEA in the cystic fluid is very low, which is not the case in mucinous cystic neoplasms in general. I have another question for you. So among these 5 sentences, which one is wrong? Is this a rare tumor? Is the tumor size over 5 centimeters a risk factor for malignancy? Is US FNA indicated in all cases? Is the 5-year disease-free survival over 95%, or is the Ki-67 over 4% associated with poor outcome? So please vote now. Don't forget what is wrong. Okay, maybe you can see it. Very good. So in this particular case, I guess US FNA was not indicated, although it provided the correct diagnosis before. Here you see that the disease-free survival related to the level of Ki-67 proliferation index, the 4% threshold provides discriminative power in these two samples. Okay, let's move to another case. This is a 24-year-old woman with non-specific abdominal discomfort, no relevant past medical history, no smoking, and laboratory data is normal, including tumoral markers. So I'm showing you the MR imaging, which basically displays a space-occupying lesion located in the head of the pancreas. It's about 3 to 4 centimeters in size. There is no associated ductal dilatation, both on the biliary tract side and on the pancreatic duct side. The lesion presents is hyperintense compared to the adjacent pancreas and hypointense if you compare to the gallbladder. You have additional imaging here, T1 weighted imaging without contrast during the arterial phase of acquisition and the venous phase. So we have an hypovascular lesion. This is the high B-value diffusion weighted imaging and the ADC map. You see that the lesion appears quite bright on diffusion weighted imaging, and the ADC map displays a value that is, I would say, an intermediate value. If you remember the value of the apparent diffusion coefficient of water, you will understand what I mean. So the patient had the US guided FNA, and this is the appearance on US. You have a well-delineated lesion. It's located in the head of the pancreas. It's basically hypoechoic, and no malignant cells were displayed. So you have here the summary, the MRI on T2, the ADC level, and the US. So use 5 proposals again: SPN, a serocystic neoplasm, a pancreatic endocrine tumor, an adenocarcinoma, or a pseudocyst. So please vote now. Okay. So, very good. The differential diagnosis was the one that was raised up between a SPN and a serocystic neoplasm. Once again, the age is in favor of A and not in favor of B. The imaging appearance is not specific for one or the other. I guess we can rule out a pancreatic adenocarcinoma since you don't have any ductal dilatation associated with a 3 to 4 centimeters lesion located in the head of the pancreas. There is no specific history of pancreatitis, and the lesion is mostly hypovascular. There is no enhancing areas inside or in the periphery of this lesion. Again, a surgical enucleation was performed. The Ki-67 index is greater than in the previous patient. And once again, immunohistochemistry performed on the specimen displayed a beta-catenin positive immunostaining, a vimentin positive, and a CD10 positive, which are quite specific. So the diagnosis in this case was an atypical solid pseudopapillary neoplasm. And indeed, the ADC was in between a malignant tumor, in which the ADC is around 1, and a pure cystic lesion, in which the ADC goes up to 3, the ADC of the water at the body temperature. So we were in an hybrid ADC situation, I would say, with a solid and a cystic component in the lesion itself. Atypical SPNs have been described. This is not that much frequent. In this particular paper in 2010, 22 out of 42 SPNs were considered as atypically. They are usually purely solid. They are smaller than the one I presented to you. And the enhancement pattern may be quite curious, I would say, because you may have an initial weak enhancement followed by gradual enhancement during the venous phase, as represented in these 3 slides here taken from this specific paper. And you see that the lesion in the delayed venous phase enhances as much as the adjacent normal pancreatic parenchyma. There is no capsule, and these lesions lack of calcified matrix. Okay, let's move to the case 3. Again, a woman, 27, HIV positive, that presented with pain in the epigastric pain irradiating to the back, so most probably pancreatic origin of the pain, associated with nausea, anorexia, and weight loss for 3 weeks. The patient did not present any diarrhea or fever, and she reported poor compliance to HIV medications that were stopped for 6 months. No previous history of pancreatitis, no smoking, and no alcohol abuse. The liver tests were normal. We had a very, very high levels of lipase, 8 times the normal range. CD4 was low, but we know that the patient was HIV positive and not taking her medication for 6 months, and the viral serology, that I don't discriminate here, was negative. So this is the CT on your left-hand side without contrast and with contrast in the venous phase. So you may see here that it's a young lady, but still the pancreas looks like enlarged in size. The lobulation is lost in the periphery. After contrast administration, we can detect an enlargement of the main pancreatic duct, downstream in the tail of the pancreas. Upstream, it looks like normal, but we don't see exactly why this duct is dilated. The head of the pancreas is also quite enlarged. We even cannot discriminate well the borders of the head of the pancreas. Patient had an MRI with MRCP acquisitions, which were quite informative because we could detect the enlargement in the tail of the pancreas associated with chronic pancreatitis changes, probably obstructive in origin, and there was a very large or long stricture at the level of the body, or the transition from the body to the tail of the pancreas, and the side branches were away from the main pancreatic duct. So we have a space-occupying lesion. This is the indirect sign of a space-occupying lesion at this level. In addition, downstream to the stricture itself, the main pancreatic duct was also a little bit enlarged. This is the Santorini duct, which is normal, and the common bile duct as well as the intrahepatic ducts were normal. So this just emphasizes also again the multiparametric approach of MRI adds value to contrast-enhanced CT, at least in this particular situation. Now I'll show you the T2 weighted imaging, which basically tells you, informs you about the same than CT, with one other difference is that you can detect that the signal intensity of the pancreas, that I will remind you in T2 weighted imaging, is more or less like the one of the normal liver. So in this particular case you have an hyperintense pancreas in the head and also in the region of the tail and partially in the body. We don't see any mass, or at least we don't have enough contrast with this sequence to discriminate a mass that is responsible for both the dilatation in the tail and the stricture in the body. So inject contrast, and we have more or less the same pattern than at contrast-enhanced CT. You have an enlarged pancreas. On the arterial phase, no mass is displayed. On the venous phase, no mass is displayed. It seems to be a ring of enhancement in the periphery of the enlarged pancreas, at least at this level in the body and tail of the pancreas. So my next question, should we perform high B-value diffusion weighted imaging in this patient? Just two options, yes or no. Okay, very good. So let's see the contribution of diffusion-weighted imaging in this specific patient. So here you have the images of high B-value diffusion. So you see that the head of the pancreas, the body and tail are affected, and you have restricted diffusion all over the pancreas. In addition, this is an overlay between the axial view of the MRP and diffusion-weighted imaging with high B values. And you see that at the level of the stricture, the area of restriction at diffusion-weighted imaging is much larger than in the body, in the tail of the pancreas and in the head of the pancreas. In addition, as you probably already noticed, we have another lesion that is displayed on diffusion-weighted imaging and affects the right kidney. And if we go back, we cannot detect that on diffusion, well, maybe on T2, now that we know the lesion is here, we could probably see it. But clearly, this is easily to detect for any of our eyes when using diffusion-weighted imaging. So, PET-CT was also performed. I remind you that we are dealing with a young patient that has a diffuse pancreatic disease, multi-organ involvement. So this is not really a surgical condition, in my opinion. This is an overlay of MR and PET and FDG PET. So this is the FDG PET. You see that you have many spots that are avid for FDG, and this quite well fit with the changes that we observed in the MR side. We have the lesion on the right lower pool of the kidney, and you have exactly the same component on the FDG PET. So what should be the next step? Already comment A, should we go for steroids? Should we go again for US along with FNA? Should we perform an ERCP or just do a follow-up? Please go ahead. Okay. So steroids versus USFNA, no surgery, I would say, and no follow-up. Some of the people suggest ERCP. I would say that I would not go for ERCP. It will display probably the same data we have already on the same pattern we have already on the MRCP. So the option here is between B and C. So I remind you that this patient has an HIV positive background and that she is not taking her medication for 6 months. So we went first to a USFNA-C that displayed, of course, an enlarged pancreatic gland with a 4 centimeters right renal mass that was not conclusive, at least the kidney biopsy, and the cytological specimen from the pancreatic head displayed an inflammatory lesion with no malignant cells, only lymphocytes and neutrophils were displayed. So I have these suggestions for you. Could this be a pancreatic adenocarcinoma in this 27-year-old woman, HIV positive, a lymphoma, an autoimmune pancreatitis, an HIV-related pancreatitis, or tuberculosis, since we are in this specific background? Okay, lymphoma, AIP. Well, for lymphoma, generally, the lesions do not affect the pancreatic duct, which was the case in this specific patient with the easily identified stricture. AIP, certainly this patient presents with a pattern that could correspond to an autoimmune pancreatitis, since he has an enlarged gland, he has strictures, and he has this ring of enhancement in the periphery of the pancreas. And in addition, she presents with a multi-organ involvement, since the kidney, the right kidney at least, was involved, at least on the imaging side, since the biopsy was considered non-contributive. HIV-related pancreatitis is an entity that is not common, but exists, particularly on those patients that are not taking their medication. And of course, in this particular setting of HIV background, tuberculosis is a condition that should be considered, although in general it's associated with also multisystemic involvement and is more focal. So we decided to start the antiretroviral therapy without any steroids in this patient, and this is the the controlled MRI at 2 months after the administration of this therapy. And you see how the pancreas changed. So now you have a normal volume of the pancreatic parenchyma, a normal signal. As I mentioned to you previously, on T2 weighted imaging, the signal should be quite similar to the one of the normal liver. And look at the MRCP, particularly the axial view. The dilatation in the tail decreased quite substantially. You can now see the duct at the level of the stricture, and the duct downstream, if you remember well how it was previously, is less enlarged. So we have a very, very good response to this therapy. The same occurred at FDG PET. You see that the lesions became completely non-habit for FDG. The situation is now completely normal after 2 months. So no opportunistic infection in this patient, no side effects of medication. There was no malignancy demonstrated and a complete resolution after treatment. So the final diagnosis is a multisystemic inflammation due to HIV replication. which mimics, in this particular patient, autoimmune pancreatitis. Okay. This is another case, a very young patient, 15 years old girl, originating from Burundi, living in Belgium for 10 years, with intermittent heartburn for several years, and recently she presented with vomiting, loss of appetite and weight loss, no fever. She had an abdominal percutaneous ultrasound, and you are here at the level of the pancreas in this axial view, and you see that there is an hypoechoic lesion that is not that well delineated. It looks like being located in the posterior segment of the head of the pancreas, and apparently we have no ductal dilatation. This is the MR on the same patient. You see that the lesion is located in the head of the pancreas. It's mainly hyperintense compared to the adjacent normal pancreas in the tail. It presents with some degree of restriction on diffusion-weighted imaging. You see the bright spots in the head of the pancreas. This is the overlay with T2 weighted imaging. The MRCP displays a stricture on the distal portion of the extrahepatic duct with associated intrahepatic duct and common hepatic duct dilatation. And on dynamic contrast enhanced T1, this is before contrast, you have the arterial phase, you have the portal venous phase and the transition phase, you have a progressive enhancement of the lesion along with contrast administration. The chest X-ray was normal. So again, an US was done that displayed this heterogeneous mass with compression of common bile duct and IVC, no cyst, no calcification, very poorly vascularized. 4 FNAs were obtained, 1 for bacteriology that was negative. That was 1 lymphocyte typing, no monoclonality was obtained, and 2 for cytology, and cytology displayed, I hope I can have it here, a negative stain for acid-fast bacilli and a very large cell with some kind of caseous necrosis. So this is before treatment and 2 months after starting the treatment, and you see in this particular patient that the pancreas became more or less normal. Again, the T2 weighted MR before and after treatment. This is just an example that complements the previous one, and I am demonstrating to you that this the aspect of a pancreatic tuberculosis. And you see before treatment and 2 months after starting the treatment, the condition on the ductal side is becoming more or less normal. Particularly the biliary ducts are decreasing in size, and you can now see the duct distal in the intrahepatic portion. Okay. A 58-year-old man presenting with asthenia, nausea, loss of appetite, no weight loss, non-specific abdominal pain in the left upper quadrant, and morbid obesity. The past medical history, well, is not really related to the pancreas. The liver tests were abnormal, but alkaline phosphatase was normal, as well as the bilirubin. The transaminase were abnormal, and the tumoral markers were normal. So this is the CT without contrast during the arterial phase and the portal venous phase. So we clearly have a space-occupying lesion located partially in the body and tail of the pancreas. We have loss of the normal lobulation. You have an hyperdense area occurring in the arterial phase in the central portion of this lesion, with the rest of the lesion which is hypovascular. And in the delayed phase, we have a kind of homogeneous enhancement like the one of the normal lobulated pancreas. MR displayed a certain degree of restriction on diffusion, high B-value diffusion weighted imaging. This is presented with the reverse window. And on T2 weighted imaging, we have this very large lesion, basically hyper-intense to the rest of the pancreas, with some septae, and the central area, which is quite bright. MRCP displayed a pancreas divisum, but this is not of importance for the diagnosis. I'm not sure, but most probably there was some kind of ductal involvement at this level, which is the level of the lesion, but without really large dilatation upstream. I still don't know if this area here, which is quite bright, corresponds to the central portion, but it could be the case that was seen on T2 weighted MR. So this is the full pattern on CT and non-enhanced MRI. So what should be the next step? Should we go for a PET-CT, an octro-PET-CT, again a new FNA, immediately do a surgical resection, or should we do a follow-up? Please vote. Okay. So no PET, but the majority are in favor of an octro-PET CT, some to US, no surgical resection at this stage, and certainly no follow-up. Okay, so a PET CT was obtained, an FDG PET, and you see that the periphery of the lesion is quite avid for FDG. The central portion of the lesion is not at all avid for FDG. US was performed, and at US, this space-occupying lesion was considered as mainly solid, and 5 times 3 centimeters lesion. The FNA was considered as non-contributive. There was splenic artery compression, but no vessel invasion, and the ultrasonographer, or the endoscopic ultrasonographer, concluded that this was a solid tumor, most probably malignant, and stage UT2 and XMX. Okay, so this is again, oh, I'm going back, sorry. So we have the PET and the US. So these are the suggestions for you. Serous cystadenoma, neuroendocrine tumor. I apologize, I don't have the octreotide PET. Pancreatic adenocarcinoma, lymphoma, or anacinar cell carcinoma. Okay, maybe we can display the bars. Okay, neuroendocrine tumor. Okay. This is probably because of the hyperintense spot on CT in the arterial phase, and the others are more or less homogeneous answers. Indeed, no one reached the perfect diagnosis, neither in our institution and in this assembly, more or less. And you see that this is mainly a cystic lesion with very small cystic cavities lined by a classical epithelium of a serous cystadenoma that was very, very uncommon since it presented with a solid pattern and in a man. Okay, so just to remind you from this multicenter study on more than 2,000 patients that the solid type of serous cystadenoma is very, very uncommon, 2% in the radiological series and 5% in the whole series examined in this meta-analysis. I have another question concerning these serous cystic neoplasms. What is wrong? More than half of these patients are asymptomatic. Location is more frequent in the tail. Indication for surgery is unclear diagnosis in more than 50% of the patients. Tumor growth is correlated with initial tumor size, or all of these are wrong. The number of answers is declining along with the progression of time. All are wrong is a major answer. Okay, let's look at it. So, more than half of patients with SCN are asymptomatic. This is true, 61% are asymptomatic. You have the list of the other symptoms and the frequency of these symptoms, so true. B. Tumor location in the tail of the pancreas. As you most probably know, the majority of serous cystadenomas are located in the head and the uncinate process of the pancreas, 40% compared to the body and tail. So this was wrong. C, surgery. The indication for surgery is unclear diagnosis in more than half of patients. That is correct. Unclear diagnosis, the occurrence of symptoms, the increase in tumor size, and adjacent organ compression are the four main indications for operating a benign lesion like serous cystic neoplasms. And D, tumor growth correlated with initial tumor size. This is also true. The tumor growth is correlated with tumor size, although the correlation is a little bit weak, but still it exists. Okay, so the good answer was SCN location is more frequent in the tail of the pancreas. I guess this is the last case. 69-year-old woman with non-specific dyspeptic symptoms for more than 10 years. All the tests were normal, except chromogranin a little bit high. No diabetes. She had a past medical history with cholecystectomy, hysterectomy, and so on. No smoking, no alcohol consumption. And she had a diagnostic workup in 2007 with MRI and contrast-enhanced MDCT. You see here that the main pancreatic duct is enlarged in the tail of the pancreas. The signal of the pancreas is more or less normal compared to the adjacent liver. On CT, we see exactly the same pattern, dilatation of the main pancreatic duct, but again, we don't see any lesion that could be demonstrated to and explain this dilatation of the main pancreatic duct. The 3 MRCPs were obtained in 2007, one in February, June, and September, and you see how fast the pattern is changing all over the year. So this is the initial examination with this non-dilated but irregular main pancreatic duct with some areas that most probably represent strictures. 4 months later, you have a larger main pancreatic duct, particularly in the tail of the pancreas, with short and long strictures. And again, in the ventral portion of the duct, you have now a subtle enlargement. And in September, the pattern again changed. Now you have clearly progressive dilatation of the main pancreatic duct. You have a stricture and a pattern that most probably could correspond to some degree of chronic pancreatitis. So, what would you do here? Do you go for ERCP, USFNA, surgery, PET-CT, or for a follow-up? I remind you that at CT we have no space-occupying lesion that is demonstrated in this particular patient. So please vote now. Okay. Good. I guess it's a good suggestion, ERCP, since the disease looks like being located, or at least affects mainly the main pancreatic duct. Since we have no mass displayed and we have no diagnosis, I would not consider surgery in this particular case. USFNA could be an option, but again, we have no mass and we have mainly different levels for the strictures. Follow-up, certainly, she has already been followed for a long period, and maybe PET-CT could also display some additional information. So we went through ERCP. This is in 2007. You see here that you have a subtle stricture here, and it was impossible to go further up to this level here, but the brush cytology was performed inside the duct with no malignant cells, which I must say is a non-contributive test, since it's okay when it's positive, but when it's negative we cannot conclude anything about it. So she had an US also twice in 2007 that displayed signs of chronic pancreatitis, but this we knew already. The dilatation, we knew it already. Hyperechogenicity also. No mass was identified, and again an FNA was performed randomly without malignant cells. So the patient went back, since there was no malignancy demonstrated, and 4 years later, without any symptoms between 7 and 11, although she had an MDCT in 2008, she presented with acute pancreatitis. This is in 2008, and you can see now that the duct is much larger in the tail, the same region. We can still do not discriminate well if there is a mass in the head of the pancreas, which is responsible for such a high dilatation of the main pancreatic duct. And the parenchyma is much more atrophic, at least at the level of the dilatation. On MR, if you remember well the first pictures of the MRCP, the duct more or less completely disappeared. We don't see the duct anymore, with a subtle, very small and short segment in the ventral portion. And again, T2 overlay with diffusion displays this very bright restriction area, which is linear and looks like being related to the duct itself. We have a small lymph node at this level. PET was negative at the level of the diffusion-weighted MR. So you have some suggestions here. Chronic pancreatitis, I guess I should delete that one because the patient clearly has chronic pancreatitis. Could this be an autoimmune pancreatitis, an adenocarcinoma, an intraductal neoplasm, or a neuroendocrine tumor? So please vote. Yes? Okay. Okay, very good. I guess autoimmune pancreatitis most probably not, since there is no enlargement at all of the gland. There is no enhancement that fits the pattern, or at least the classical pattern of autoimmune pancreatitis. And clearly, the lesion looks like being located in the ductal area and not in the parenchyma. So the patient was operated, and you see here the macroscopic specimen. This is the main pancreatic duct, and you have the microscopic specimen with this proliferating lesion inside the main pancreatic duct. This was a malignant lesion, and the final diagnosis was an intraductal neoplasm. This is a new entity. Well, at that time it was a new entity, which is named tubulopapillary neoplasm, and it was stage T3N0M0. And I just would like to emphasize that this neoplasm should be differentiated from a classical IPMN. In both cases, you have a dilated main pancreatic duct, but in IPMNs you have abundant mucin, and generally the duct at the level of the solid area expands much more, which is not the case in ITPNs or even in neuroendocrine tumors. The immunohistochemistry is not helpful in these particular situations, with the exception of MUC5AC, which is negative in ITPNs and positive in IPMNs. And both lesions have a relatively good, compared to pancreatic adenocarcinoma, 5-year survival rate, more than 30% for this lesion here, that I remind you was evolving for more than 4 years, and 27 to 60% according to the IPMN series. So I hope I could demonstrate to you that an experienced multidisciplinary team is a need for dealing with pancreatic lesions, and particularly these kind of lesions in these young patients. The differential diagnosis and the management should incorporate not only our imaging patterns, but certainly the clinical judgment is very, very important to make the next step, and the role of the pathologist is determinant. So thank you very much, and I would like to acknowledge my 2 colleagues from Brussels for helping me to put this together. Again, enjoy the rest of the day and have a safe trip back.